Cardiac symptoms in children, yeah, it is, as you all know, it is the basics, and once you have the basics strong, then your clinical evaluation would always be strong. So especially for the PGs, this is going to be, helpful to you all through your lives. You have to have the symptomatology and history taking absolutely strong. All right, so yes, every encounter with a patient should begin well, and you know that our evaluation starts from history, goes into physical examination. If you find any point in physical examination which you think is not in line with the history that you got, then you have to go back to your history and re-elicit it and corroborate it with the physical examination. Same with investigations. If you find something in investigations which doesn't fit into your history and physical examination, then you go back and forth and corroborate everything, and that is the way to reach a proper diagnosis so that you can make a proper plan to help the patient. And so a focused and informed history gives a solid base to your clinical evaluation. What do you need for a thorough history? You need to be well versed with symptomatology. So you should know what you should ask in your in your history from the patient, and that depends, and that is the whole thing that we talk as symptomatology. So what are the cardiac symptoms? The classic 6 cardiac symptoms are dyspnea on exertion, fatigue on exertion, angina, chest pain on exertion, syncope, palpitations, and cyanosis. When it comes to pediatrics, we have to think in terms of its age-specific equivalence as well. This is very important because no infant is going to come and tell about dyspnea on exertion. So we always have to think about age-specific equivalence in pediatrics. Other points that we have to note in cardiac history in pediatric cardiology include recurrent respiratory tract infections, which is primarily lower respiratory tract infections, and failure to thrive. These could be due to underlying heart disease, primarily large left to right post-tricuspid shunts, but other causes need to be ruled out. When you mean a post-tricuspid, it includes like after that, when you consider from the anatomy of the heart, post-tricuspid means it will include VSDs, aortopulmonary windows, and patent ductus arteriosus, not generally pre-tricuspid shunts, which include ASD or PAPDC. So what are the implications? So if the parents or the child complains of any of these of these 6 cardinal symptomatology features, you should think about and rule out a heart disease. And on the other way around, for every child whom you need to rule out heart disease, you have to ask about each of these symptoms and make sure there are none. If there are any, you have to elicit a detailed history of each. Points to note include not all cardiac symptoms might be suggestive of critical heart disease or heart disease at all. There might not be any underlying heart disease, but then they might give you any of these histories. On the other way around, even more important is that not all critical heart diseases or heart diseases even might not present with these symptoms as well. Many of them could be asymptomatic, especially children tip off much late in the pathophysiology. So it is important to note that not all of them come with these histories. And do not ignore any point in history taking. So now we'll go one by one into each of these points. Dyspnea. So you all know that dyspnea is defined as an undue or unpleasant awareness of one's own breathing. Tachypnea, is increase in respiratory rate, and you know how it is defined in infants, older children, and in neonates. More than 40 in infants, older children, and more than 60 per minute in neonates. And the causes of dyspnea could be either cardiac or respiratory. So when you think about dyspnea from a cardiac point of view, it implies either pulmonary venous hypertension or hypoxia. Either of these, when a patient has either hypoxia or pulmonary venous hypertension, sometimes both combined, they can present with dyspnea. Two terms which often come up when we discuss dyspnea in cardiology include orthopnea and PNT. This doesn't imply much to infants, but then this could be present in older children and adolescents especially. So orthopnea is dyspnea which occurs within minutes of lying down, and the mechanism is straightforward. It is venous return increase and decreased movement of the diaphragm in the supine position. And PND is a classical feature of left ventricular failure, which occurs 2 to 3 hours after sleep, and it is also relieved in the sitting position. And the mechanism is different from that of orthopnea. And there are 5 or 6 mechanisms which have been, 4 mechanisms which have been proposed for explaining paroxysmal nocturnal dyspnea. So the fluid resorption is also there in PND, but it is this late PND, which is late after lying down, is due to resorption from the extracellular compartment, not from the intravascular compartment. Then depression of the respiratory center during sleep is supposed to contribute, and increase in sympathetic activity is also supposed to be a significant contributor to the mechanism of PND. And it has also been implied that transient nocturnal arrhythmias can lead to the same. So as we discussed, dyspnea indicates either pulmonary venous hypertension or hypoxia, which can be due to cyanotic congenital heart diseases also. So how does dyspnea occur in cyanotic congenital heart diseases? You know that there is hypoxia. Hypoxia is part of cyanotic congenital heart disease. It can cause acidosis, and either of which can cause a stimulation of the respiratory center and lead to tachypnea at rest. And you know that hypoxia worsens during exercise because the right to left shunt increases due to systemic vasodilatation and increased heart rate and venous return. So and that is how a hypoxia worsens during exercise. And how does left heart failure cause dyspnea? So I will explain it in a little bit detail, because this is sort of the basics of whatever happens in cardiology. And managing heart failure is an integral part of pediatrics as well. So I'll just go into a little bit of detail of this. So heart failure, is the pathophysiologic state in which the heart, via an abnormality of cardiac function, fails to pump blood at a rate commensurate with the requirements of the metabolizing tissues, or is able to do so only with an elevated filling pressure. So this elevated filling pressure is key to heart failure. Once you understand this and how it causes dyspnea and the whole mechanism or underlying pathophysiology of heart failure, you will be able to manage heart failure much better. So what are the normal filling pressures? The normal left ventricular end diastolic pressure is around 7 to 11 millimeters of mercury. On the right side, it is around 2 to 6 millimeters of mercury. And if you look at the left atrial pressures, the mean pressures are 6 to 10. The mean pressures closely reflect the left ventricular end diastolic pressure. Similarly, the right-sided atrial mean pressures reflect closely the right ventricular end diastolic pressure, because we know that they communicate in diastole. So what happens in heart failure? As we looked into the definition, now we know that in heart failure, the heart is pumping at an elevated end diastolic pressure. So the end diastolic pressure of the left ventricle is increased. So in diastole, naturally, it is in communication with the left atrium. So the left atrial pressure increases, and left atrium in turn is communicating with the pulmonary venous system. So the pressure gets transmitted to the pulmonary venous system, and it causes pulmonary venous hypertension. The worst stage of which is called frank pulmonary edema or left heart failure. So that is how it goes. So how does pulmonary edema cause dyspnea? So there is transudation of fluid into the interstitium first, and then into the alveoli, which leads to increased respiratory effort. The lungs are congested and you need more effort to move the lungs to the J receptors get stimulated, and they stimulate the respiratory center in turn. Also, this increased respiratory effort without a proportionate increase in lung expansion leads to intercostal or subcostal retraction, which is very commonly seen in infants with heart failure. How do we grade dyspnea in older children and adults? We all know that NYHA class is used. In NYHA class, it is very easy to remember with that ordinary and a sign more than less than. So the class 1 is asymptomatic, where dyspnea happens only with more than ordinary activity. In class 2, dyspnea happens with regular ordinary activity. In class 3, it is dyspnea with less than ordinary activity. And class 4 is dyspnea at rest. Mind you, this is applicable only for older children and adults. How do you do that in infants? We have a classification system, which is the Rose classification, which is class 1, 2, 3, and 4, which closely parallels the NYHA. Class 1 is asymptomatic. Class 2 Rose is mild tachypnea or diaphoresis with feeding in infants. So feeding is an activity of exertion in infants. So that is why you actually use it to grade with the Rose. And class 3 is marked tachypnea or diaphoresis with feeding in infants, or even prolonged feeding times with growth failure can be classified as class 3. Class 4 is retraction, grunting, and diaphoresis at rest. Now we go to the next symptomatology point, which is fatigue. So exertional fatigue denotes inadequate skeletal muscle perfusion during exercise, which is a feature of reduced cardiac output. And when you hear about it, you can think about cardiac causes like congestive heart failure from any cause, or ventricular outflow tract obstruction. So when you exercise, your cardiac output is supposed to increase. But if there is a roadblock, if the outflow of the right or the left ventricle is obstructed, then the heart cannot increase the cardiac output, and it is perceived as exertional fatigue. So this can happen in severe pulmonary stenosis and even in pulmonary hypertension. Even when there is pulmonary hypertension, the increased pressure in the pulmonary system and sometimes the increased PVR can act as an obstruction for flow of blood from the right to the left side of the heart, which in turn contributes to the cardiac output. Similarly, in fixed left ventricular outflow tract obstruction, like in aortic stenosis, valvular, supravalvular, subvalvular, you can have exertional fatigue. Now, feeding difficulty, we would look into a little bit of detail because that is an age-specific variant of exertional dyspnea and fatigue in infants while sucking. So what exactly is feeding difficulty? So when baby sucks at nipple, there is dyspnea and fatigue, the baby stops. After a small feed, the baby rests for a few minutes and starts sucking again. So that is suck, rest, suck cycle. So this is classic feeding difficulty. But sometimes not all of them will give you the history this classically. Some of them might only point to like prolonged feeding times. Then you prompt and then you might elicit that, okay, this is what is happening. Or there would be just dyspnea and forehead sweating while sucking. So unless you prompt and get a proper history, you will miss this. So that is important to note. Failure to thrive. So what is the pathophysiology of failure to thrive in congestive heart failure in children? So congestive heart failure, generally leads to feeding difficulty. And hence, we know that this will ultimately end in decreased calorie intake. And in CHF, there is increased catabolism, and there could be recurrent respiratory infections, which can lead to less intake and more demand to handle each respiratory infection. So all of these contributes. In addition, there is systemic venous congestion. So there is also portal venous congestion. So there is mucosal edema in the gastrointestinal tract, which can lead to anorexia and decreased absorption from the GIT. Also, failure to thrive may be part of a syndrome like DiGeorge or rubella syndrome. And failure to thrive can lead to low immunity and again lead to recurrent infection. So it can be a vicious cycle and it needs to be tackled at the earliest. How about recurrent LRTI? So it can be the best definition of that is more than 4 to 6 episodes of lower respiratory tract infection in a year, or 2 episodes requiring hospitalization or IV antibiotics. And as I mentioned already, it is seen commonly in post-tricuspid shunts, which include VSD, PDA, AP window, and not generally in pre-tricuspid shunts. And we know that, why it happens, because the post-tricuspid shunts generally cause left ventricular failure and pulmonary venous congestion. So again, CHF and recurrent respiratory tract infection pathophysiology, poor weight gain leads to poor immunity, recurrent infection. Again, the second thing is interstitial edema and pulmonary venodilatation, as we already discussed, which can lead to compression of the bronchioles and retention of secretions, which can lead to recurrent infections, which predispose to recurrent infections, in fact. So if you look at what happens to the in the circulation in the lungs, there is pulmonary venous congestion. The anastomotic channels between the pulmonary veins and the bronchial veins open up, and this leads to bronchial mucosal congestion and goblet cell hypertrophy, which leads to impaired mucociliary clearance, and this predisposes them to recurrent infection as well. Also, another mechanism which has been implied is a dilated pulmonary artery in large left to right shunts. It can compress, especially the left one because it is above, can compress the left bronchus, resulting in retention of secretions and impaired clearance. So that also predisposes to recurrent respiratory infection. Now, coming to the last part. So the three symptoms that we'll be discussing together include angina, syncope, and palpitations. These are classically in like older children and adolescents, but then we will go a little bit into detail because history taking is very important in these. So the most important step in these three are history taking, because it is impossible, or it's impossible to get higher end investigations for every patient presenting with these symptoms. So we have to segregate from history and physical examination and routinely available tests as to who requires step 3, step 2, or step 3, step 4 workup. So the problem with these is that, majority of them might not have any underlying structural or other heart disease, but when present, it could be a fatal disease also. Hence, we need to be like alert when anybody complains of these. So as I already mentioned, baseline workup might not tell you the diagnosis, but why this is important is because we have to choose who needs really these higher end, say, third and fourth level workups. So chest pain, it's generally unlikely to be cardiac in origin, but then exertional chest pain in children can also be due to coronary obstruction in Kawasaki sequelae. Like there was Kawasaki, and ultimately it led to aneurysm and some stenosis, and then that is causing real coronary obstruction and ischemia, coronary ischemia, like in adults. Or there could be a myocardial oxygen supply demand mismatch in left ventricular or right ventricular hypertrophy, or like in pulmonary arterial hypertension, or either of the ventricular tract obstructions. Or it could be from an anomalous coronary origin. So some of the sometimes the coronary can originate from the inappropriate sinus and go in between the arteries, or could be intramural, and this can lead to symptoms. And sometimes the presentation is with syncope and sudden cardiac death in athletes as well. So this is an important thing to remember. And of course, you are all well aware of ALCAPA. We know that it can present with distress and irritability during straining. It can present as an angina equivalent, and other causes include like pericarditis and sometimes mitral valve prolapse as well, in especially in adolescent females. So ALCAPA, we know, can present with features of heart failure in infancy. Some improve as collaterals develop, but older children may present with angina, dyspnea, or syncope on exertion. So ALCAPA has the dubious honor of the disease which presents with anginal attacks at the earliest age. It's around 6 to 10 weeks when the PVR falls. While feeding, the paroxysmal attacks of discomfort, the infants can present with expiratory grunts, followed by marked pallor and cold sweat, with the appearance of shock, and can even lead to transient loss of consciousness. So here is a history checklist for this, for chest pain. You have to ask about duration, whether it was minutes or hours, or it is permanent. Sometimes they say that it is always there, which is seldom cardiac, I would say. We can say never, but only seldom. You have to ask about precipitating and relieving factors, whether it is exertional, or, is it related to any particular food, or, was there any history of injury? You have to ask about associated symptoms. Do they have palpitations, sweating, or syncope associated with it? You have to ask about history of prolonged fever with rash or peeling, or even a definitive history of Kawasaki admission, history of prolonged fever with joint pain, or whether it is a known Takayasu, family history of young MI or sudden cardiac death. In those children, we have to evaluate for lifestyle diseases as well as thrombophilias, depending on the family history, and always check a forelimb blood pressure. Syncope, again, it is defined as a transient loss of consciousness due to decreased cerebral perfusion with inability to maintain postural tone and spontaneous recovery. So this definition by definition, seizures are excluded, coma is excluded, shock is excluded, and other states of altered consciousness are excluded. So the types, common ones include vasovagal or neurocardiogenic, postural hypotension, postal orthostatic tachycardia syndrome, or syncope as a cardiac symptom. So primarily what we have to do is to rule out neurological causes also when, patients present with such a history. Some of them will give you a clear cut history and that, okay, this can only be cardiac. And some of them will be very clear cut and from the history itself that, okay, this is neurological, and then you don't need to do additional workup for them. But if there is, if the history is not clear cut, then you might have to investigate on the either side. Like, you might have to investigate for neuro as well as cardiac issues. So predisposing factors for vasovagal syncope include dehydration, intense emotional stress, anxiety, fear, pain, hunger, use of alcohol or drugs, crowds where there is less oxygen, more carbon dioxide around, standing for a long time, more so in the sun, classic histories, school assemblies, hyperventilation, which is breathing in too much oxygen and getting rid too much of carbon dioxide quickly, coughing forcefully, turning the neck, wearing a tight collar, which is due to carotid sinus hypersensitivity, urinating, which is micturition syncope. So essentially everything is history. You ask history, whether it is vasovagal or not. If it is vasovagal, you know that you don't need to go to the second and third level of investigations. It can be managed by lifestyle modification. And syncope is a cardiac symptom. It could be either exertional or at rest. Exertional happens more commonly in ventricular outflow tract obstructions, as we already mentioned. When the patient is exercising, the cardiac output has to increase, but it cannot increase because there is a roadblock. So then what will happen? There is not enough blood to the brain, and so the patient develops syncope. So and that is one cause of syncope as a cardiac symptom. And exercise-induced arrhythmia has also been implicated in exertional syncope from the cardiac point of view. So syncope at rest, positional syncope, which is LA myxoma, is a classic cause. Like, it moves around, and it can vary with position. A Stokes-Adam attack, or which is syncope in complete heart block, or other profound bradycardia due to asystole or ventricular fibrillation. So this can occur at rest also. It wouldn't be necessarily on exertion. So, again, your history checklist, you have to ask whether the loss of consciousness was complete, was it with a rapid onset and short duration, which is classical cardiac, was recovery spontaneous, complete, and without sequelae. Like, that is classically to differentiate from seizures, where you will have a post-ictal phase, and loss of postural tone. So that is also classically associated with syncope. So if the answers to these questions are positive, the episode has a high likelihood of being syncope. So if you have a clear-cut history, you can work the patient up accordingly. So that is why history is important. So you have to ask about the duration, post-event phase, precipitating relieving factors, family history. That is very important. So a family history of sudden cardiac or unexpected death or unexplained fainting spells. So that is an important pointer towards genetic arrhythmia syndromes, and these patients might need costly second and third line workup. And it is worth it. So it all depends on how you elicit the history and pull up these factors from history that you can decide on further investigations. And of course, medications and drugs you have to check, because many of them can cause dehydration, vasodilatation, and alter the pathophysiology to predispose the patient to syncope. Palpitations, unpleasant awareness of one's own heartbeat. So that is the definition. It could again be exertional, at rest, or paroxysmal. In younger children, parents may complain increased precordial activity or neck pulsations. Children may just describe it as chest pain sometimes. Some kids can come and complain about chest pain, and there could be even an ongoing arrhythmia, might be an SVT. They will not be able to say palpitations. They might say chest pain because they really don't know how to express what is happening. So you have to keep that in mind when dealing with children. So exertional palpitation is classic in volume overloaded hearts, example ASD, MR, AR. Palpitation at rest may be due to volume load or due to arrhythmia also. Paroxysmal palpitation, what do you mean by it? You mean abrupt onset and offset. It is always abnormal, and it is most likely arrhythmia. And there is generally no warming up and warming down in this type of arrhythmias. It is, in one heartbeat's time, the rate changes. So the patients may have polyuria during the palpitation, and vagotonic maneuvers like straining at stool may sometimes terminate the palpitation when it is, especially when it is like SVTs. And again, you should keep these checklists handy. I had handed it out to the pages at Kottayam when I was there. Once you do the checklist and you pick up everything from the history, then rest of the investigations and workup becomes easy. You have to ask about the duration and frequency. Was it fast or slow? What are the precipitating and relieving factors? Is it exertional or is it at rest? Are there any associated symptoms like syncope, sweating, or other cardiac symptoms? Family history of sudden cardiac death. Again, this is very important. Medications, drugs, and always check forelimb BP. Insist on event ECG. So that is important. So event ECG means at the time of symptoms, did you take an ECG? So, if you have an ECG when the patient had palpitations and it doesn't show anything, then most likely, you might not need further investigation. On the other way around, if you have an abnormal ECG while the patient had palpitation, that is the best to diagnose, because even when you consider electrophysiology studies, what they look into first is the event ECG. If the event ECG is there, then everything becomes much more easier, even when you consider like costly investigations and invasive investigations. So that is very important. And, Holter can help only if the symptoms are frequent. Like if you have daily symptoms or at least alternate day symptoms, then a Holter can help. Otherwise, you put the Holter for 24 or 48 hours. In that time, the patient never had palpitations, then there is no point in doing it. So, you can tailor the investigations depending on your history. That is why you need a detailed history, and that is why knowing symptomatology is important. And now cyanosis. So yes, definition we all know: bluish discoloration of skin and mucous membranes due to increased concentration of reduced hemoglobin. Causes can be anything from CNS, musculoskeletal system, airways, alveolar capillary membrane, hemoglobinopathies, and cardiovascular. Central versus peripheral, cold extremities with cyanosis is peripheral. Cardiac versus respiratory. The classic teaching is peaceful cyanosis is cardiac, and respiratory distress generally implies a lung cause. So how do you evaluate a cyanotic baby? Is the baby really cyanosed? You can check with SpO2 and you can confirm it as long as you spend time getting a good tracing and a dependable SpO2 value. And then the second question, is the cyanosis central or peripheral? For that, you have to keep the baby warm and recheck. Third is the cyanosis cardiac. So you look at whether there is respiratory distress. You can look at response to oxygen. So the hyperoxia test was classically used, for various reasons. It has not been, the classic hyperoxia test with an ABG or arterial blood gas is not advocated anymore. But then, you can just see with 100% oxygen what is happening to your SpO2 rather than doing an ABG and doing the classic hyperoxia test. It takes time, and in that time you can actually get other workups done. As of now, hence it is not recommended. Of course, you can go to X-ray and ECG and other bedside echocardiogram, etc., to rule out cardiac cause as cardiac cause for cyanosis. Spells, yes, I will go to it into a little bit detail. I don't know if there is time. I hope so. So spells very important practically as well as from exam point of view for PGs. So spells is defined as progressive increase in the rate and depth of respiration, culminating in paroxysmal hyperpnea, deepening cyanosis, limpness, syncope, and occasionally in convulsions, CVA, and death. So spells can be quite dangerous in cyanotic congenital heart disease. Classical age is between 2 months to 2 years, peak incidence 2 to 6 months. It is important to note that worsening of cyanosis on crying is not a spell, but crying or exercise may trigger spells, you have to remember. So the mechanism, again, I am sure most of you are well aware, but I'll just go through once more. So as a baby has a bowel movement, or as a baby is crying or feeding, there is the primary thing that changes is the sympathetic system. So there is sympathetic stimulation, which leads to an increase in heart rate and cardiac output. So there is infundibular contraction, and with this exercise, there is increased venous return and right to left shunt. This worsens the hypoxia. So now the PO2 is decreased and the pH is decreased, and the respiratory center is stimulated. So that leads to hyperpnea. Now, the increase in respiratory rate will further increase heart rate and cardiac output, and this enters into a vicious cycle. So squatting for relief of dyspnea, I am sure, I hope with Hridyam and early management of congenital heart disease, so we never have to see this again. But then squatting for relief of dyspnea denotes top leg physiology in younger children. Older children and adults learn to restrict activity to avoid squatting. There are many squatting equivalent positions, sitting with leg drawn underneath, legs crossed while standing, or mother holding the baby with the knees drawn towards the chin. So these are squatting equivalents. What happens is when you squat, the femoral arteries are kinked and leads to an increase in systemic vascular resistance. And also it locks up desaturated lower limb venous blood pressure when the femoral veins are kinked, and displaces better saturated mesenteric venous blood into the heart. So these all help, in relief of dyspnea. So squatting for relief of dyspnea has been a classical symptom of older children with unoperated cyanotic congenital heart disease. Cyanosis in special situations, differential cyanosis. Cyanosis more either in the lower limb or in the upper limb. So Eisenmenger PDA is classical, where you know that there is right to left shunt through the PDA and the lower limbs are cyanosed, but the upper limbs are not. You can get a similar physiology in a persistent pulmonary hypertension in the newborn. Reverse differential cyanosis, we know that cyanosis is more in the upper limbs and less in the lower limbs, classically described in TGA coarctation and PDA. You can sometimes see this when you do SpO2 screening in newborns. If you have somebody with TGA, coarctation, and PDA, you will see this reverse differential cyanosis. A normal heart with cyanosis, you can have an absolutely structurally normal heart, but still a cardiac cause of, still a cyanosis. It could be either a pulmonary arteriovenous fistula or a systemic venous anomaly, like IVC draining into LA or an LSVC into LA, which might not be very apparent in a first go cardiac evaluation. So, cyanotic congenital heart disease patients with decreased pulmonary blood flow, that is TOF and TOF physiology, they present more often than not with visible impressive cyanosis. But then something which I always keep saying is that cyanotic congenital heart disease patients with increased pulmonary blood flow, that is TGA VSD, GRV VSD, single ventricle without PS, TAPVC without obstruction, many of them have saturations more than 85%, and it might not be visible to the eye, to the human eye. So you have to be, and these are the diseases which, if the surgery is delayed, the pulmonary vascular resistance rises, and obstructive pulmonary vascular disease develops much earlier than the corresponding counterparts like VSD. So, they might actually present like a VSD, but if you delay proper diagnosis and management, these kids will suffer more. So it is always important to keep this in mind, that the increased pulmonary blood flow cyanotic CHD kids might not present with as impressive cyanosis as you would expect them to, or it is not like the decreased pulmonary blood flow kids. So always check SpO2, spend some time in getting a good tracing, and that will help you go a long way in overall managing the baby. And thank you for your patient listening.